Initially labeled as a failed back syndrome. There was an implication that probably the surgeon was responsible for it, and has now been changed to post-operative persistent pain syndrome, whatever you want to name it. This is something that dogs all spine surgeons, and every month we have a couple of them who are not very happy, at least for the initial part. What is the incidence? So from as high as 36, I would put the average incidence in our institute to nearly 10%. Uh, it may not all be very severe, but there are majority of them are mild symptoms with maybe paresthesia, but these all come into this. What could be the etiology? There are various papers coming up with various etiologies for this. Most of it is probably inadequate decompression or instability, synovial cysts, pseudomeningocele imbalances. You can go through it, but this is what you get in lumbar disc herniations. You probably have had a reherniation. You've not taken out the index disc completely. You've had an epidural fibrosis. There have been intense inflammatory changes around the nerve root, or you have battered the nerve root while taking it out. So, a lot of people want to do minimal access surgery without doing adequate exposure inside, and that's when you have a cramped up space. You've not taken out enough bone or ligamentum flavum, and you want to pull out this. They're going to injure the root, and that kind of radiculitis is never going to go away. It's going to haunt you all your life. So inadequate exposures, these are the ones that cause this. What would be the reason in T-lifts? More than 10% of T-lifts will have some amount of residual pain post-op. Most commonly seen when you combine a BMP with MIS T-lift, then followed by open and then MIS T-lift. There are various factors to this. One of the things is BMP. We used to use BMP like water when I was in my fellowship days about 16 years back. And then there was this big blowback where we started getting a unacceptably high. More than 50% of our patients would, if they didn't wake up with it, develop radiculitis within a week or two. And then when we went back, there was an intense inflammatory reaction. In some cases, the entire foramen used to be ossified, and we literally had to drill through that ossification to go down and free up. So any inflammatory product left there. Other thing is, a disc is an avascular structure. So when you're going in for a primary discectomy and taking it out, and if there's a residual fragment remaining, there is also going to be a very intense inflammation around it, and the nerve root is going to give you grief there. Mishandling of case. I'm going to discuss each one in detail later. Well, this is a study, very interesting, of MRIs done on the day post surgery, 3, 7, 21 and 42 days. And what they found that the adhesions of the chorda equina inside, if they were there pre-op, they continued to be there for a week post-op. So the immediate post-surgery, there is no reduction in the inflammation of the roots, so the chorda equina. So it takes time for it to go down. There will be an intense reaction which will, over a period of time, reduce down. But by the time you're about 6 to 12 weeks post-op, you should expect your the roots and the inflammations to go down. There is a shrinkage of the arachnoid space immediately post-op, which can also be one of the reasons. But most of these inflammatory changes will settle down in about 8 to 10 weeks. So this is what the radiologists have found which could contribute to the reasons. And since everybody runs and gets an MRI done or a CT scan done post-op, I borrowed these studies from the radiology journal, where they have classified it as early and late radiculitis, and these are the reasons what they found for early radiculitis, and these are the reasons for late radiculitis. I'm going back to the slide. So a radiologist will pick up instrumentation malpositions, cage malpositions, bone grafts that have slipped out, or hematomas and fluid collections, or that are there, or pseudomeningitis. And late, of course, there will be instabilities, there will be reherniations, there will be scarring, there will be adjacent segment disease, and non-unions that would be causing, and late infections. Early infections are the ones that are there within the first 6 weeks of surgery. But you would see a fair amount, when I say a fair amount, more than 1.5% infections that will set in 3 to 6 months after the index surgeries. Very commonly seen in diabetics, and In our country, because we give antibiotics, majority of them will give antibiotics till suture removal. So this just suppresses a minor infection which later on presents as the bacterium sets in and chronic osteomyelitis happens. There are various ways of going through this. These are papers who tell us we need to take proper history and all. These are the gives that all of us have gone through. We have to do it. Once you have this, you got to sit and what like Arvind went through his checklist. So I have a checklist of every patient where if things go wrong, what went. First thing is the pre-op. Dr. C.A. Tarwakar, my PG teacher, always made us do, Dr. Dhar will agree with, a pelvis with both hip X-ray for every spine patient that was to go for a surgery. The reason being, one of the most common reasons for the so-called claudication is avascular necrosis that we miss. With MRIs and screening of hips, this is something that has gone down, but are we looking at a wrong diagnosis? Did we diagnose wrong? Was it a diabetic neuropathy? Was it a vascular claudication? Was it an avascular necrosis? Or did the patient have psychological problems? So these are things that this patient would never improve or would deteriorate after the surgery. These are your pre-op failures that we have to work for. Intra-op, did we operate the wrong level? That's in spite of doing checks, especially when you're doing an L4-5 and L5-S1. If just a 10-degree head high by the anesthetist is going to land you up at the wrong level. It has happened to us, so be very careful of that. Did you do an adequate surgery? Was your decompression enough? Was the discectomy done properly? Were all the fragments in the canal removed, or where there was something retained? Was there any damage to the neural structures? Did you retract harshly? Did you retract beyond the midline? Especially when you do minimal access surgery and you put in a tube and you try to retract it medially, you have to understand that the tube goes at an angle, whereas in an open surgery you're looking bang in. So those stretches can happen. Enthusiastic assistant in the effort to show you better might end up damaging structures. Did you damage the facet joints? A lot of us very casually remove the facet capsule while doing a decompression. That's one of the prime reasons for having instability and post-op pain. And of course, positional. We have seen a series of myalgia parasitica type pains after we changed our bolsters, and we had to go back and check, and there were stiffer bolsters which gave rise to the whole week. Everybody who got operated, if the surgical time was more than 2 hours, they woke up with numbness and pain. Other thing is if the patient has severe stenosis and listhesis and you corrected it, by natural attitude they crouch down, and once they are corrected, there is a stretch on the anterior hips capsule as well as the psoas causing pain, which can masquerade as radiculitis. It settles down fortunately. Well, post-op, it can be recurrent disc, infection, instability, change in posture, like I said, an adjacent level disease. Scarring is something that can rarely be helped. It continues beyond. Fortunately, most post-op radiculitis, especially the ones that are not due to fragments left behind or battered nerve roots, will show a positive recovery in more than 90% of the patients. Thank you.